So my presentation today will be about the effect of keloid properties on treatment efficacy. So as we all know, the clinical presentation of keloids is very variable, ranging from patients who develop one or a few keloids in their lifetime to patients who develop extensive disease on several parts of their body in a few years. And the efficacy of keloid treatment is highly variable in both clinical practice and in literature. And this treatment efficacy may strongly depend on keloid and patient characteristics. So as my colleague Juliette already talked to you, is that we did a survey a while ago among dermatologists and plastic surgeons in the Netherlands, in which we asked for their preferred treatment of each type of keloid. And it appeared that the results were very different. Many different combinations of first-line treatments were chosen, even in a small geographic area. For the small keloid on the cheek, 27 different first choices were opted, and for the keloid on the jawline and chest, even more options were chosen. And that means that the treatment a patient gets largely depends on the treating physician. And that poses a risk, of course, for unequal care and health outcomes. That's why we need evidence-based guidelines for selecting the most efficacious treatment for individual patients. And for this, a standard keloid classification is needed based on the most relevant clinical properties. A few studies have attempted to differentiate different clinical subtypes of keloids. The International SCAR classification from 2002. Oh yeah. The percentage is? And this one? Yeah, now it's working. Okay, I think so, but I'm not sure if this is. Yeah, so I was talking about that a few studies have attempted to differentiate different clinical subtypes of keloids. The International SCAR classification in 2002 divided keloids into minor and major, where major keloids were defined as keloids larger than 0.5 centimeters. Dr. Tergan talked to us earlier this symposium about his proposed TNM staging system, in which the number and diameter were predominant parameters. Then another study proposed the morphology and maturation combined both factors and differentiated the nodular keloid, the superficial spreading, also known as the butterfly keloids, the mature keloids, which are the non-growing burned out keloids, and finally the transition group when the keloids couldn't be classified into one of above stated groups. And as you can see, the criteria used in the proposed classification systems differ widely, and also those classification systems have not yet validated in clinical practice. And we thought it would be useful to look broadly into the literature, performing a systematic review, aiming to identify clinically relevant keloid properties that may influence treatment efficacy. And we did it also with colleagues in Rotterdam. In this review, we included only RCTs due to the strongest evidence inherent to those studies. A comprehensive electronic literature research search was performed in the following databases: the Cochrane, Embase, Google Scholar, Medline, Web of Science. And the search included articles from inception until August 2023. Title and abstract screening was performed by 2 reviewers, and hereafter the full text was assessed for eligibility. And studies were included when the RCT was in English, and assessed the efficacy of any keloid treatment in patients of all ages with at least one keloid property analyzed. This is the flow chart. 1,520 studies were screened after identification and duplicate removal. And after full text assessment, eventually 16 studies were included in the review, involving 1,113 patients. And those were the studies that provided a separate analysis for keloid properties, including the duration prior to treatment, location of the keloid, size, history of recurrence, baseline Vancouver scar scale, the Fitzpatrick skin type, baseline POSAS, ethnicity, etiology, thickness, and number of lesions. I'm going to walk you through the results. First of all, the keloid duration prior to treatment. There were 12 studies involving 811 patients that looked at the relation between the keloid duration and the treatment outcomes. And of those 12 studies, there were 3 studies that reported a higher efficacy in younger keloids compared to longer existing keloids. One of the 3 studies showed a higher efficacy in keloids shorter than 2 years, and different treatments were used in that study. However, no sub-analysis was performed per treatment group. And then 2 studies used either Nd:YAG laser or cryotherapy. Those studies showed that there was a relation between keloid duration and treatment effects. However, this study did not report on the cutoff point for duration. And all other studies did not show any significant correlation between duration and treatment outcome. Considering the keloid location, there were 7 studies involving 440 patients, and 1 study that used triamcinolone acetonide showed that there are higher cure rates for keloids on the cheek, forehead, mandibular area, and lip when compared to the pinna. 1 study showed higher efficacy for keloids located on the trunk compared to the extremities. In this study, they used either triamcinolone or verapamil. And 1 study showed higher efficacy for keloids located on the earlobes, face, and back compared to the chest and shoulders. Different treatments were used in this study, and no sub-analysis was performed per treatment group. And for other studies, no significant correlation was reported. Considering keloid size, there were 3 studies with 195 patients, and 2 studies reported higher efficacy in smaller keloids, which were defined as smaller than 1 square centimeters or less than 5 cubic centimeters after respectively contact cryosurgery or 5FU. And another study showed that there was no significant correlation between the keloid size and treatment outcome. Considering the history of recurrence, there was 1 study involving 26 patients. This study showed that volume reduction of 40% versus 1% in naive versus recurrent keloids. And those keloids were previously treated with corticosteroid injections or excision. And in this study, they applied intralesional cryotherapy. Then considering the baseline Vancouver scar scale, there was 1 study with 60 patients. This study showed that there was a higher efficacy in keloids with higher baseline Vancouver scar scales compared to keloids with lower scores. And this study used Botox PRP or triamcinolone, but no sub-analysis was performed, and also no specific cutoff points were reported. Considering all other keloid properties, no significant correlation was found with treatment efficacy. The risk of bias assessment was performed and was found to be low in only one study, and in all other studies it was high, either high or having some concerns. And the quality was particularly low due to bias arising from the randomization process, deviations from the intended intervention, and selective reporting. So several discussion points arose from this study. First of all, which we already talked about a lot in this symposium, is the diversity of outcome measures used, which makes it challenging to compare results among many keloid studies which are done these days. There was a low number of eligible studies, and those studies also had very small study populations. A lack of sub-analysis was performed by treatment group. And in this study, we looked at keloid properties, but of course, other factors are playing a role as well in treatment outcome, such as patient-related factors. Then in summary, only a minority of RCTs performed a separate analysis for specific keloid properties, and even fewer studies found clinically relevant keloid properties. Based on this study, a lower treatment efficacy was identified for keloid with a longer duration, location on the chest, shoulders, extremities, pinna, having a larger size, history of recurrence, and a lower baseline Vancouver scar scale. However, of course, the clinical relevance of other properties cannot be excluded, since we had only a small number of studies with small sample sizes and also limited quality. And more high quality RCTs using validated outcome measures should report on the potentially relevant keloid properties to ultimately develop an evidence-based treatment algorithm for clinical practice. Thank you.
Okay, thank you very much, Dr. Qiqi. An excellent review. Are there any questions from the audience? Yeah.
Okay, and thank you for this excellent review. How do we know for sure that the keloids were not mixed up with hypertrophic scarring? Did you look at those articles that they indeed treated keloids?
Yeah, as far as the articles mentioned it, and if the articles didn't, also included hypertrophic scars, the article would be excluded from the review. But it's a very important point, and I think there's also a research question we have to further investigate in future.
We present.
You
will introduce them.
Introduce.
Any other questions?
Any other questions for the speaker, last speaker?